This is an overview of the respiratory system. In the first part, we discussed how anatomically the respiratory system is divided, and for revision it is divided into upper and lower parts. The dividing line is the true vocal cords, and we have seen details of these structures of the larynx and particularly the vocal cord. At the moment we will discuss the lower respiratory tract parts. The lower part of the respiratory system starts below what? It starts inferior to the true vocal cords. Let's have few questions on this slide. We can see the larynx, and inside this larynx there is the true vocal cord. Below it is the lower respiratory tract parts, and the first part of the lower respiratory system is the trachea. The trachea is going down to divide into right main bronchus and left main bronchus. The trachea is also called the windpipe, and part of it is in the neck and part of it is in the thorax, in the superior mediastinum. We would be looking into these details in few slides that are coming. Now, the level of the trachea starts at C6 and it gets down to the level of the disc between T4 and T5. This level of this disc represents the posterior part of a transverse section through the sternal angle. What is the sternal angle? It is the joint between the manubrium sterni and the body of the sternum. Let's ask a few questions about this view, which is a nice detailed view of the trachea and its main branching. The end of the trachea ends at the level of the sternal angle, where it divides into right and left main bronchi, and the trachea in itself, as we can see, it is a midline structure. It should not be deviated to the right or to the left, and it has a cervical part, and from our remarks on this image we can see that the trachea is made of rings, incomplete rings. The incompleteness is posterior, and we can see that between rings there is a fibrous tissue connecting these rings, and as it comes to the sternal angle it divides into a shorter right main bronchus and a much longer left bronchus. It's important that we write these notes presented in the previous slide. The main primary bronchus. There are two primary bronchi coming out of the trachea. There is the right main bronchus, which is wider in caliber, shorter, and more vertical, while the left main bronchus or primary bronchus is narrower, longer, and more horizontal. Why longer? Because there is the heart in the middle mediastinum, and the heart makes a good impression on the left lung called cardiac notch, and this is going to make the left lung a little bit further away from the midline. Therefore, it needs a longer main or primary bronchus. Here is more data about the trachea. It starts just immediately below the cricoid cartilage of the larynx. It travels for some distance in the neck and then gets into the superior mediastinum, ends at the level of sternal angle, and divides into right and left main bronchi. In cross section, the question is, which structure is posterior to the trachea? The answer is the esophagus. What is the description of the esophagus? The esophagus is collapsed tube that dilates when a bolus goes down. Now, from where it brings this space to dilate in? Posteriorly is the vertebral column and cannot provide any space. Anterior is the trachea, and therefore you can find that trachea is made of incomplete rings, and the incompleteness is posterior facing the esophagus. This is the incomplete fibrous ring, and what connects the two ends of this incomplete ring is a smooth muscle called trachealis muscle of the trachea. And to prove that we need a trachealis muscle, it is the presence of the esophagus posterior to the trachea. To fix the idea that the trachea has incomplete cartilaginous rings, I will leave this slide for you to comment on, and you can see that it is made of incomplete rings of cartilage, and you can see where is the trachealis muscle and what is the mucous membrane of the trachea. Here is a slide showing the larynx superiorly, then the trachea, and as the trachea comes down into the superior mediastinum, we see the major great vessels of the heart and the arch of the aorta with its main branches. Now, what point needs description? First, the arch of the aorta is in front of the trachea, and the arch of the aorta as it turns to the left, it is superior to the left main bronchus. Then, after the arch of the aorta turns on top of the left main bronchus, it comes down as the thoracic aorta, and it is posterior to the left main bronchus. This is endoscopy of the trachea. An endoscope is pushed down into the trachea, and you can see at the periphery the presence of incomplete cartilaginous rings. Going down the trachea with the endoscope, you reach the point of bifurcation. This point of bifurcation in this image is marked green. This is a very sensitive area called carina, and this carina is sensitive to foreign bodies and any excessive secretion. When it is stimulated, the person coughs very violently. And this is an endoscope. When you go down the trachea, you reach the point of bifurcation of the trachea into right and left main bronchi, and here you find the openings of the two primary bronchi. The trachea has a single windpipe that comes into the thorax to get into the lung, and you may remember that our target is to have as many alveoli as possible, and to achieve this we need branching and branching and branching to around 22 generations of branching. And this is what happens. This is the trachea, a central single windpipe, and the point of bifurcation is the carina, and here is the right primary bronchus, and here is the longer left primary bronchus. And look, the right primary bronchus is going to give a secondary bronchus. Secondary bronchus enters a lobe of the lung and continues, and then gives other generations of secondary bronchi. The left primary bronchus is going to give 2 secondary, while the right will give 3, because the right lung has 3 lobes. The left lung has 2 lobes, so it gives 2 left secondary bronchi. The secondary bronchus is going to divide into tertiary bronchus, and the tertiary bronchus is going to enter a pulmonary segment, the functional unit of the lung. These are the origins of tertiary bronchi. This tertiary bronchus is going to enter a pulmonary segment, and there are 10 segments in each lung. These are segments of the lower lobe of the right lung. These are 5 segments of the right lung. These are the 2 lungs, the right and the left. Now, the right lung is divided into 3 lobes: superior, a middle, and inferior lobe. Then, between lobes, there are fissures fissures are deep indentation of the lung tissue, and between the superior lobe and the middle lobe there is what is called the horizontal or transverse fissure, and between the middle lobe and the inferior lobe there is another fissure called the oblique fissure. Now, to summarize, in the right lung there are 3 lobes and 2 fissures separating the 3 lobes. On the left there are only 2 lobes, a superior one and an inferior one. There is no middle lobe in the left lung, and since we have 2 lobes, we have 1 fissure, and it is the oblique fissure. Now, if you look at the lower border of the left lung, you can see an indentation that is not present in the right, and this is called the cardiac notch. It is impression of the left ventricle of the heart, and there is at the bottom a word called lingula. This lingula is part of the upper lobe that gets anterior to the heart between the chest wall and the heart. Now, when you look at the left side, you see a lung. Which lung is this? This is a lung that has 3 lobes and 2 fissures, therefore it should be the right lung. If you look at the mediastinal surface of the lung, that is the figure on your right, you can see what? What is this? This structure is the blue colored structure, and therefore this is the pulmonary artery getting into the lung, carrying deoxygenated blood. And this red structure is the pulmonary vein, which is bringing oxygenated blood to the heart. And most posteriorly, this is another pulmonary vein, and most posteriorly you see the point of entry of the main bronchi. So what is the arrangement here? The arrangement here is most inferior are the pulmonary veins, anterior is the pulmonary artery, and most posterior is point of entry of the air passages, the bronchi. This is a good exercise for you, first of all, to figure which lung is this. It's written on the slide, but it needs explanation. Plus, you can see at the hilum of the lung, the place of getting in and out of structures, you can identify the different parts of structures getting in and out of this hilum, and you can see that posterior to the hilum there is an impression of an arch. Explain, this is an impression of what structure? These are the 2 lungs. For the sake of comparison, look for differences in fissures, look in differences of the lobes, look for differences on the medial side of the left lung, there is a notch and explain what is this notch. This is an image of what is called Thoracic Inlet, and it is made by the vertebral column, the first rib as they come anteriorly and meet the manubrium. Here you can see that the apex of the lung is in the neck. It is superior to the first rib. What is this image telling me? It is telling me that the lung has different segments. Now the segment is the functional unit of a lung, and the tertiary bronchus gets into this segment and divides many times into bronchioles and then terminal bronchioles and the rest of the story of the alveoli. This is a diagram of a pulmonary segment where you can see that there is a bronchiole getting in, and this bronchiole is dividing into more smaller bronchioles, and then the starting of presence of alveoli. And this pulmonary segment or pulmonary lobule, they are surrounded by connective tissue septa, so they are separated from each other, and they are supplied by arteries, veins, and lymphatic vessels. Let us write down and notice important facts. First of all, the terminal bronchioles are end of the conductive pathway, and the bronchi, they are going to divide into bronchioles, which are lined by simple columnar or cuboidal, and bronchioles have no cartilage in the walls, no rings, and the rings are replaced mostly by smooth muscles, and when they contract they produce bronchoconstriction, and you pharmacists have drugs that are going to dilate these respiratory passages. Now the lungs move with inspiration and expiration, and once they do that, just like the heart, they need a cavity lined with a serous membrane in a situation similar to the heart. In the heart we had serous pericardia made of serous membrane, and we have a visceral layer on the heart and parietal layer lining the fibrous pericardium. The pleural cavity is the same. The pleural cavity is made of the pleura, in which the lung invaginates. It does not open the pleural cavity and gets in. It invaginates in the pleura, and so we have visceral pleura sitting and covering the lung, and we have parietal pleura lining the anterior, inferior, and lateral and posterior parts of the thoracic cage. It is useful to sit down and write some notes about what we have discussed and what we have seen. So the pleura is a serous membrane. What does serous membrane mean? It it means that it lines a cavity that does not open to the outside environment, and it extends from above the first rib and into the root of the neck, because the lung, the apex of the lung, extends above the first rib. Then we have the visceral pleura, the pleura that covers the lung itself, and we have parietal pleura, pleura that covers parts of the chest wall and whatever makes a wall or any part of the pleural cavity on the sides of the mediastinum. Therefore, we have costal parietal pleura lining the inside of the chest wall, and we have the diaphragmatic parietal pleura, covers the diaphragm as it makes the lower end of the thoracic cavity, and we have mediastinal pleura covering the mediastinum on its sides. Here are the landmarks of the lungs and the pleural cavity. Anteriorly, the horizontal fissure is along the sixth rib, and the oblique fissure extending along the line from the sixth to the sixth intercostal space and then to the seventh rib. And anteriorly, the lung ends at lower border of eighth rib, while the pleural cavity ends at the level of the 10th, although it is here marked as the 9th, but it ends at the level of the 10th rib, while on the right it is the level of the lungs and the level of the pleural cavities are the same, except the presence of only oblique fissure. What is this arrow pointing at? It is pointing at the apex above the clavicle, so the apex of the lung and the pleura, they extend above the clavicle, and here is the lower end of the lung, and this is the lower end of the pleural cavity. A question arises here as a conclusion. So the pleural cavity is a little bit larger than the lungs, because the lungs, they need to expand, and when they expand they need a space. This is a posterior view of surface markings of the lower end of the lung and the lower end of the pleural cavity. So the pleural cavity is larger than the lungs. This is the end of the image show. In the next few slides, if you are interested, check your knowledge and check your understanding, and may I suggest that if you don't understand something, go to the mind map and copy it, or copy the part that you are not sure of.